Hi, everybody. Welcome back, friends, to another episode of the ASAP Pathway podcast. I'm your host today, Dr. Stacy. I am always excited to sit and have a conversation with my good friend and colleague, Dr. Mike DeLuke. Um, those of you who listen regularly know who he is. I get emails, I get texts constantly when I have him on because he's so engaging, he's so knowledgeable, and he's such a caring healthcare provider. And it just is obvious when he speaks that he's passionate about this movement. He's passionate about helping kids. He has the ortho coach. He helps dentists. He helps orthodontists navigate how to jump in and help these kids in their practices. He also is the founder of the Doc podcast. So check him out there. But today we're just going to catch up. It's been since 2024, which I can't even flip and believe. Or no, 2023. We're
Yeah.
in 2024. Yeah, Mike.
Yeah.
I can't even believe it. It's like Happy New Year. It's May. So let's catch up. So welcome, Mike.
It's
Yeah.
great. I mean, it's been an exciting, I know, like I can't believe, as you were alluding to, it's been that long. I'm really excited to touch base with you. I always enjoy catching up with you. Thank you for the very gracious intro as well. I really find that we just share a philosophy in so many ways. I listen to your content. I enjoy it. You are a very good podcast host. As somebody who
Aw.
knows what this takes on this side of the microphone, I get it. It's not easy. Your interviews you're just a very, very talented interviewer. And I mean that. What you get out of your guests, one way I try to judge someone's ability in an interview, what any interview I'm listening to is whether they make their guests comfortable and whether they can get their guests to open up on the topic they want to speak about. And you do that. And I've learned a lot. I want to talk about some of the guests we've both had on, and some of the same.
Yes.
And I think that's even more cool because I've realized this airway circle it's a big circle, but it's a very tight knit circle. It's an interesting, as I'm learning more, and I was, up until basically last year, I was a wet fingered orthodontist who just did this all day, every day in my practice, and was kind of removed from the bigger movement here going on in the country and in the world to help kids, especially. It's where my focus was in the airway arena. I was just seeing these things in my practice. I was doing these things with my treatment approaches, and I realized I was helping kids in ways that I wasn't taught to help them, that I never learned how to help them. I was starting to really pick the brains of my ENT and allergy colleagues and just start to open my mind and expand my horizon on what is possible. And then when I developed the passion to really, I always had the passion, but developed the plan to put into action that passion to go teach on a bigger scale, I really started to meet people such as yourself, and you have been so great to introduce me to other people, and then that another person introduces me to other people, and next thing I know, you recognize the same names over and over again. And it's just been so neat to see how quickly this is moving. And I don't know if you feel the same way, but I
Yes.
feel like, yeah, there's the paradigm shifting, that pendulum, it's not swung the way we need it to yet, but I think we've reached the point of max doubt and skepticism, and we are a group of us, and I play a very small, if any, part of that. I'm happy to play any role I can, but are starting to raise enough awareness of this topic. And that's really my purpose, is to say, hey, wait, we have a role here. And as dentists, right? Dentists, whether it's your general practitioner, orthodontist, pediatric dentist, we have a role, and a primary role, in the airway awareness and recognition of the signs and symptoms of sleep disordered breathing, and what that does to the craniofacial growth and development, as well as neurocognitive growth and development of our patients, especially our younger patients. And parents are getting it. I have parents reach out to me who follow my podcast. They've gone online and I have some free CE content as well as some paid content, but they've literally taken the free CE courses. Like, they are watching this. They're reaching out to me, asking me if I know a provider in their area who can help them with this. So I'm sensing in the past 5 months, kind of the end of that long answer of the past 5-6 months here, is I'm feeling way more optimistic than I was when we spoke last time. That article had just come out in the AJODO and the digital
Yes.
version, right? The
Yes.
one about, like, if you want to talk about airway, be a physician. And
Yes.
it was kind of like, I was feeling like there was lot of negativity being heaped upon us. I'm sensing it changing. So I don't know. What do you think? Have you found something similar?
I have. I feel the same. I think there's always going to be the people that, you know, dig their heels in,
Mm.
and they are going to die on that hill, kind of
Mhm.
like they are just. And I think since the last time you and I were on a podcast together, there was a recent, um, there's a famous blog of an orthodontist that
Mhm.
we both know that, I guess there was some back and forth about mouth breathing doesn't, since when has mouth breathing ever been really a problem? Mouth breathing doesn't cause anything. So all this mouth breathing talk needs to go away. And I mean, I sometimes I sit back and I just shake my head and I'm like, I'm not even gonna waste my time. I
Yeah,
couldn't
yeah,
help it on that one when
yeah,
there's that Karen Bonnick study, and I'm
yeah,
like, "Are you kidding me? How can
yeah.
anybody say that?" But,
And I
um
think that rallied a lot of us because I had you and I both engaged on that, and I have the
yes,
same philosophy. And it's like some of this you just you have to weed out some of the noise and the
you
naysayers,
do,
because
yeah.
otherwise you can't make progress, because you're spending your time trying to put out fires and convey. It's that analogy of there's kind of three tiers of people in your life in any capacity. There's the kind of the bottom third, who you're never going to change what they think or what they believe or agree with you or like what you're saying or doing. There's the top third, who will always somewhat be supportive and believe. And then there's that middle third that isn't really sure. And I find when you focus on that bottom third, the ones who are just going to hate on whatever, you really take your energy. You don't support the ones who believe in you, and you miss the opportunity to take the ones who aren't sure and help them understand and believe in you and what your cause is. So I try not to spend a lot of time. And in our lives, I find we tend to focus so heavily on that bottom third, that it just, because we want to please, we're healthcare
Yes,
providers. We want everyone to see how awesome this is and how much we can help kids. But it sometimes it helps to just say, you know what, that bottom third is who they are, and we're not going to change them. But the
yes,
difference with this was, and I'm fine saying it. So Kevin O'Brien, who has a
yes.
blog, Kevin, and he's out of the UK. I don't know Kevin personally at all. I've seen some things he's put up over the years, and he's passionate about what he does in the profession, and I respect that. Whether I disagree with someone or not, I mean, I can certainly admit if someone's trying to put information out there and he believes in what he's saying. That being said, the study he referenced was a study about teenagers following, I think it was like, maybe, don't quote me on the years, but like 12-ish years old to like
Mhm.
16, something in that arena. And some had expansion, rapid palatal expansion, and some did not. And they looked at the AHI, which again, this we
Yeah, we
my
can
blood pressure is already rising as
well,
I'm
you say
recording.
AHI and we all get a
I'm like,
little aggravated.
and he talked about the study. He quoted this study that said that, okay, they because of this, because they found that the AHI in those who had expansion was like one-ish or something. And I haven't looked at this since we all went through this months ago. And then they found the ones who didn't have expansion was similar, right at the end. That really expansion has no difference on sleep apnea and the apnea hypopnea index. And that was the post he put up. Was this little summary he gave, was that stating essentially that expansion doesn't have anything to do with AHI or I think he said OSA at that point. And there's a difference between trying to convince that bottom third to agree with you and calling out the bottom third for their bullcrap.
Yes,
And I felt like at that point it
that
was
was different.
disinformation. That was
Yes.
different. You're misinforming people. And I replied very sternly, and it not really isn't really my MO to be that inflammatory from the start on things. I'll fiercely fight for what I believe in, but I got to do it with some tact and grace. But I just felt it needed a short, quick response to state my displeasure. So I said what he said was misguided and misinformed and misguided. I think something to that effect in one of the social media forums. And it came back as, well, why? That people were kind of defending him, defending me. And then I said, you know what? Going back and forth online is futile. You have time to respond. You can kind of do it hide behind your keyboard and sit there. Let's have a debate. You and me. Let's have a debate. And I said, I can host it. I'll post it to the doc community that I have on Facebook. We can do a Facebook Live. Like, we'll just do
Let's
it.
just talk, have a
You and I.
conversation.
And because he questioned me on like what's wrong, why is it misguided and misinformed? And I said, I think it'd be very much more effective. So he comes back and says, I will not debate you verbally because you will twist my words and all these
Ah,
sorts of. The more appropriate way to do this, the way this is always done in academia, is you will submit a 500-word response detailing why this is why to support your statement. So then this thing blows up. And then people are coming to my side like, no, it should be verbal, just debate. And then other people are saying like writing these huge things like the essence of a true academic debate is in writing. And I mean, it was like, it just what
it's
happened, it devolved
ridiculous.
so quickly in social media, which
It,
is why I wanted to do it in writing anyway. Or, excuse me, which is why I wanted to do it verbally and not in
yeah.
writing anyway. And then he was saying he'd post it to his blog. So I'm like, well, how do I know you're going to even put everything I say on your blog? Like, I don't know you. And then he's like, you're questioning my credibility. I mean, it just, it's like, I'm not quite, I'm just saying,
What's
is like,
interesting, it's like he's accusing you of twisting his words, but now you're
right,
questioning his credibility. He
right.
threw you under the bus like someone that would do something like that. It's just so, it's a circular, you just can't even, again, it's like, I debated even saying anything because I'm like, you can't throw pearls to swine, kind of thing. I
Mm-hmm.
don't mean to be mean, but gosh, at some point you're like, look, it is what it is, and you're obviously not going to agree. And we have said a million times, someday, it's going to be years and years before all the research. I mean, shoot, we can't even agree on what the objective definition of sleep disordered breathing is. I mean,
Right.
so we're looking at quality of life, which more and more is coming out that that's what matters.
Yep. Yep.
And, so we are using things like the PSQ, which has been
Mm-hmm.
validated and, you know, looking at parents and looking at kids and doing what we do best. And, um, look, I had a little girl in my chair this week. She's 4 years old and she has crowded lower anteriors in primary,
Wow. At
like,
4 in her primary
and
dentition,
her
right?
primary, like,
So much for the
they're
Bogue spaces.
overlapping each other.
Oh.
Like, I whew, it's and then you're having the conversation with the parents that, developmentally, she's behind and deficient in the bone, and we gotta
Mm-hmm.
she's had a hiccup in her growth and development. Let's get her back on track, but we
Mm-hmm.
need to ask why she's like this. So, these are things we're doing in our practices every day, but
And you know what that is, Stacy? That's I don't know if you're familiar with Peter Attia.
I'm not.
And he's a physician who I don't think I don't know if he practices still or not. Really fascinating guy. He's got a podcast, Outlive. He wrote a book, Outlive,
Oh,
and
I'll have to check it out.
yeah, it's really interesting book. And but one of the things he talks about that I really like is exactly what you're saying. You just said it there, and what he labeled, and going back to Kevin O'Brien, and what we were saying is there, this group of naysayers like, where's the evidence? Well, you can pick apart that study that he put in a million ways. So whether you use AHI as a valid indicator in kids, right there off the rip, you could basically, we've talked about that before on our
Right.
own shows and with each other in these joint shows. You could talk about the selection size, how quickly the expander was turned, skeletal maturity of these kids. Do they have lymphoid tissue involvement, nasal passageway involvement? It was so siloed, and it's such tunnel vision of us. And I'm not faulting the people who did the study at all. Like, that's
Right,
great.
right,
They do the
right.
studies, get this stuff out there. Our job is to analyze it and constructively discuss it, and not that, like, Kevin O'Brien's my teacher, I need to submit a 500-word essay to him. No, how about you have the courage, if you're going to put this stuff out there, and the challenge still exists. Actually, Brian Anderson, who runs another group, who's great, he offered to mediate it, because that was the other thing. He's like, you're going to slant the questions. And so I said, why don't we have a neutral mediator? So Brian stepped in and said, I'll do it. I'll ask it. I'll make sure you both approve of the questions ahead of time. And I was like, let's do it. You name it, we'll do it. And Kevin wouldn't do it. So Kevin, the offer still stands. That being said, there's a big difference in what the other thing they say is evidence-based, right? We need these randomized controlled trials. And your episode with Steve Carsonson, he talked a little bit about this too,
Yeah.
but and he didn't say it in this way, but what Peter Attia says is the old traditional style of Western medicine, right, is based on sort of the traditional gospel is this sort of go through these blinded studies and try to create this placebo controlled randomized trials, and that's that evidence based. Where medicine needs to head, and I put us in that because this becomes a very medical systemic issue when we're talking about sleep health and sleep hygiene and airway, is evidence informed.
Mm-hmm.
And the difference is exactly what you just said with the PSQ. That's evidence informed.
Mm-hmm.
Know conclusively that if a parent says, their child is snoring and not performing well in school and wetting the bed and having restless sleeper and mouth breathing, and we look in their mouth and they're 4 or 6 or 8 or whatever, they've got these narrow arches and not enough room for their teeth, and their tongue doesn't have space, and they've got dark circles under their eyes, and they're not thriving. We know that is evidence informed medicine. We know there is a problem, right?
Right.
Why do I need a randomized controlled trial over the next 20 years to look at what that kid's going to be like in 20 years? I feel like that's malpractice. I feel like we need to turn that tide and say, no, 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 no. I'm not going to let that kid suffer for 20 years to be part of some study.
Right.
And maybe be the one that doesn't get the treatment, right? Because in a randomized controlled trial, you got to have some that get treated and some that don't. I'm not going to subject some human, some wonderful child, to be maybe in the placebo group, right? And not get any treatment and see just how dysfunctional their life is in 20, 30, or 50 years. Because that's the Harvard study. There's studies out. These would have to take the Harvard aging study. I mean, these studies have to take decades and decades to have the type of validity that these people are seeking. And they know they're not going to happen because they're unethical. You can't do that. We're not talking about a terminally ill patient who you're trying some experimental medication because it may work, it may not.
Right.
You're talking about a life of a child here. And so I feel like they're using that as a bit of a crutch to kind of be like, you don't have the evidence. Well, no, this needs to be evidence-informed decision-making, which is exactly what you are describing with that 4-year-old.
Well, I like that. Evidence informed. That's a first. I've not heard that before. I really like the term. What's his name again? This
Peter
physician?
Attia. It's Attia.
Okay, yeah, I'll have to check him out.
Yeah, he's got a podcast too. And he's I kind of, not that I'm anywhere near where he is with what he's doing with his career, but he was a clinical practitioner for a lot of years who saw a lot of the things in medicine that I was seeing in orthodontics and in dentistry that were so different than what we're taught, what traditional medicine was teaching them, and how they don't get anything on gut microbiome, and they don't get anything on, it's reactive medicine, not proactive medicine.
Mm-hmm.
And he's much bigger into the proactive side for lifestyle changes. And it's exactly analogous to what we are talking about and have been talking about and are so passionate about. We're talking about proactive care using evidence-informed decision-making to help patients. And why are any colleagues of ours, and I'm not, this isn't rhetorical, I actually would love to hear your thoughts. Why do they oppose that? Like, I still, maybe I just need to get over it, but I can't get over the why. Like, what is in it for people to not want us to help these kids?
And it's interesting too, like the physicians that have referred to me, like to help these kids, like, hey, tag, you're it. Like, we've done TNA removal. We have they're not compliant with CPAP. We've done the Flonase. I mean, we've done all this stuff, and it's helped some, but there's some missing pieces, and it's usually the craniofacial component. They most of them are kind of like, we've seen in the literature it can help some children, so tag, you're it, why don't you just do it?
Right.
There's so much more open, it seems,
Right.
to just like, well, it's helped some children. It's the malocclusion needs to be addressed anyway. I mean,
Thank you.
just do it. Tag, you're it. Like,
I
what?
actually asked the residents yesterday, why are we waiting? Because the residents, I was talking to them about this in my lecture yesterday. And I said, again, a serious question. Why do we have to wait in orthodontics? I don't know what your thoughts are on that, but I don't know.
And it's, why is it that any deficiency, hiccup in growth and development that we see any other way medically, we intervene?
Right.
The only time, I mean, like, there are some conditions that they're like, well, this is slow growing and it's more risky if we intervene. So let's keep an eye on
Fair.
the child. I
Yep.
want to do
Yep.
a once a year evaluation because the risk benefit,
Yep.
you know,
Studies show they outgrow this in a
yeah,
year. Right.
that
Yep.
malocclusion is never outgrown. If anything, it worsens.
Yep.
It's never outgrown. We know this based on papers from, over 100 years old. Um,
I
so
love
why
that.
aren't why aren't we?
Malocclusion is never outgrown. I've
No.
never heard it said that way, but that's a great thing to say.
So
It's so
why
true.
aren't we addressing the hiccup in growth and development as soon as we see it? Now, I understand there might be times that, and this is something Tracy talked about once. It was really, well, talks about it all the time in ASAP, but you might hear you're not going to get any changes really with that mandible maybe till we have that growth spurt later in
Sure.
life.
Yep.
Okay, but once again, what is our diagnosis? So if you have a child with sleep related breathing issues and they are choking
Hmm.
every night and suffocating on their tongue, and like um uh Dr. McIntosh has talked about this,
Mm-hmm. Yep.
where he's like, it's like someone's breaking in your house at night and choking your child. You would do everything in your power.
Hmm.
You would be standing guard by that bed, like, not on my watch. You're
Yep.
not putting your hands around my kid's throat. You're
Yep.
not choking my kid.
I love it. I love
So
it.
why? And he's an ENT out of
Yep.
Australia, very
He's
proactive.
amazing. Yeah.
He
He's
is
on my
David
list to get
McIntyre.
him
Yeah,
on the show. Yeah.
he is great. And let's just call a spade a spade. Kid's choking. If your kid was awake, going,
Yeah.
choking, you'd
Gasping
run
for
them
air.
gasping for air. You would be wanting to do the Heimlich. You would want to know what the
Right.
obstruction was. You would be taking them to the emergency room. You
Right.
would be demanding the pediatrician help you. So
Oh, that's such a good point.
it's no better. If anything, it's worse because our
Yeah.
inhibitions are different. We're higher parasympathetic tone at night. The defense mechanisms are a little bit, we're just not as guarded in our
Down.
sleep.
Yeah. Not as guarded. Yeah.
We're vulnerable.
Yeah.
So I don't know where I was going. I'm on a rant, but here's the thing. Like,
Doing it with the younger kids,
yeah, oh, the
even
growing the
though you might
mandible.
need the definitive growth modification to
Right.
time with puberty and adolescence, going in younger.
Agreed. But what's the diagnosis?
Right.
I have a child choking. I might have to put them in something that
Right.
brings the jaw forward, because what am I treating? Yes, I'm expanding transverse. I'm getting as much maybe sagittal growth that the body's willing to give me at this age, but I got to get that mandible forward at
Mhm.
night. Why? Because the diagnosis, yes, they have a malocclusion. Yes, they're class 2. Yes, I understand that the growth spurt is more ideal to actually work with that mandibular growth. But if they're 7, 8, 9 and they're choking on a retrognathic mandible, I have to get the mandible forward.
Yeah, it's such a good point. It's true. And as
What
long
is
as
the
you educate the
diagnosis?
parents, right? What's
Yes.
the etiology? Getting into that ideological mindset, which I say these things and I'm always like, I don't want to make it like I'm disparaging my orthodontic colleagues because I'm not.
No,
I really
no.
just try
Yeah.
to call balls and strikes on this. And I love being an orthodontist. I love the orthodontic community. I love this profession. I wouldn't be trying to,
Hey,
you
I
know,
love my I just want to say, as a primary care dentist, like, I love my orthodontist. They're so knowledgeable. I want to give you guys cred, like the growth and development that you guys learn. I mean, I my hat goes off. We just got to get, um, they're just so much more capable of doing things than they're willing to recognize that they weren't taught in residency. And I think
yes,
that's the issue.
yes, that's it.
Is they
And
just have
actually,
to continue their education beyond residency.
yes, and that is something I actually wanted to talk about, and I'm glad you brought that up because on the side of not sitting here trying to make disparaging remarks about
Right.
my profession or my colleagues, I I feel I have a responsibility as someone who's been intimately involved in the clinical side in my own practice for almost 20 years that I started and grew from the ground up to the academic side, which I've been on faculty in hospitals, in orthodontic residencies, GPRs, cleft craniofacial teams, my entire career, and continue to now. I've gotten to see both sides, and I've really seen the disconnect between the clinical side and the academic side. It is huge. It is a wide rift between the two. And one thing, which goes beyond scope of obviously today, but I do want to try to work on ways over the years to try to help mend that gap. That being said, it exists right now. And I like to ask the residents questions about these things because I find they are so inquisitive and smart and dedicated, and it's why I'm so passionate about teaching, because I learn from them. They question me, they make me think differently about things. And one of the residents said to me just yesterday, after we were talking about this, they said we went to clinic and they're like, the thing I don't understand about why orthodontists are so resistant to this is if we know that adult patients who suffer from sleep disorder breathing or obstructive sleep apnea, whatever it is at that point, if we know they have narrower palates, if we know they have more retrusive jaws, why would we be opposed to starting to fix that as early as possible? And I'm like, bingo. Like, so to answer your question of why we're not, I think as soon as they're exposed to it, so I really don't think it's like, oh, all these orthodontists, they're wired to not believe in this stuff. No, I don't think so. I think because as soon as I start to teach them, they are so in tune to this. And I have to say too, I feel like this new generation has much more of like an empathetic sort of service orientation to them. I don't have more than just sort of some empirical examples on that, but I just get a feeling that they're really into wellness, health, overall. They don't
Quality
want
of life.
quality of life. Yes. And I think when I start showing them these kids that are suffering and the picture of this 6-year-old with the dark circles and the open mouth, and I say to them, like, this is your kid. This is your child. Do you want the healthcare provider? Let's say you're not an orthodontist, to be like, I can't do anything for her for now. Studies show that this won't help her. When you know that she has a tiny little upper jaw and a small lower jaw, and you could go in and do some things to help her out, and they all get it. So to your point, I really do believe our educational system in medicine and dentistry is failing us. And the reason why is these orthodontic residents, by and large, there are some outlying programs, but for the majority of them, they're not treating these kids young enough. And the faculty and people who run the programs never learned this way themselves. And so I'm not saying this is a criticism, it's just the reality. It's really hard to teach and believe in something you've never seen, done, or learned. And
Yes.
if the faculty haven't seen, done, and learned it, then they can read all the studies they want about. They can read the Bonnick study. They can read all the studies going back in our profession from Engel talking about this, how mouth breathing was a major contributor to malocclusion. You can see all of that, but still not be able to incorporate that into the educational system. And then the last thing is we need the ADA and the AAO to step up in the accreditation side and start to put some standards on these programs to look at this stuff.
Yes. And what's interesting? I was thinking about this the other day when I was referring out on your point with why not get things going, correct things when it's maybe less traumatic, easier to do. I mean, when they're young, they're so malleable and soft, and
What was the word you used in one of our mush? What
they're
he
they're
used?
squishy and
Squishy.
they're juicy.
Juicy. That was it. It was juicy. I love
Their
it. Yeah, I love
maxilla,
it.
I got that from
Yeah.
Mariana Evans. They're
Yeah.
juicy. Their
Yeah.
maxillas are juicy.
I
But
love it.
think about wisdom teeth. Okay. We used to say, well, I used to say, okay, you're about 17, 18, maybe you're early college. All the oral surgeons were slammed over the summer
Yep.
with college students getting out their wisdom teeth. Well, my oral surgeons in town have told us we'd actually prefer if you do it a little earlier now
Mm-hmm.
before the roots form because
Mm-hmm.
it's less traumatic and the
Yep.
healing's easier and they're younger.
Yep.
So then now I'm referring out 14, 15-year-olds in some cases, depending on the development of the
Yep.
wisdom teeth, when they look more like a little marble
Yep.
versus all the roots are formed. And oh my gosh, now we're doing this and they just scoop right out.
Yep.
Now we're hearing of, shoot, we might even be able to get in there and inject something in the tooth
Right.
bud before
Enucleation and yeah.
and
Yep.
and not even worry about the wisdom teeth. So it's the name of the game in medicine is always about early intervention when possible. The
Mm-hmm.
name of the game is always about as less traumatic as possible. Let's make the biggest impact when possible. Why would that be any different with orthopedic, craniofacial orthopedics. Like, why? Why? It's just not even logical to think otherwise.
Because it just hasn't been done. And I think until it's meaning become the norm, it changes so hard.
It
And we've talked
is.
about this part, and I, I see it every day in what I'm doing now in this capacity. I see it more and more and more. And it is, and then I think about, because I try to maintain sensitivity to what it took me to change when because again, I've said open, I wasn't trained this way. I didn't
Right.
understand this side. I got no education on airway, and I had an amazing residency and learned a ton. And I never would have become the orthodontist that I'm able to be if I didn't have that training. That being said, I didn't have anything on the airway side. And so when I was seeing this, and I didn't have anything on really early treatment other than if they've, 8 years old and they've got a posterior crossbite, you put an expander in. But outside of that, I didn't have anything on the growth and development side for those younger kids. We learned it in theory, right? We learned the growth of the skull from infancy all the way up through adolescence and adulthood into adulthood, but we didn't learn in putting it into practice. So I think, to answer your question, if you've never worked with it and then you go to change, it really does transform how you run your practice, how your team, I mean, even the scripting for your team. I mean, think of just, you're in it now. I'm a little removed, so I'm looking back on when I went through these changes, which was really in like the 2006 when I was kind of starting my practice, 05. So like that era, that first 5 years when I was starting to realize just pulling teeth on these kids is not the solution that's really solving anything. I'm treating the symptom, not the etiology. And then evolving into like, well, there's kind of 5 years later, maybe. So the early like 2010, 2012, there's some airway stuff I'm seeing, and got my cone beam in 2014 and started to see, whoa, there's like a whole new world here of things that I could see and detect. And each time I did that, it was a real major change for my practice. It was stressful. It required implementation of new technologies, new techniques, new
Yes.
training of my team, scripting for my treatment coordinators, patient literature that we would give to them, right? And in terms of what we're doing. And each change, even when I went from doing it with turnkey expanders on young kids to doing it with braces and wires, that was a whole change in my scheduling, in my scripting, my inventorying, and chair time. I mean, it all is a lot. And I think sometimes it's just because when you're doing this as an orthodontist and you're waiting and you're ignoring these issues or pretending that the literature supports that you don't need to do anything about it, even though we know that there's a lot of there's plethora of data that exists to state otherwise or improve otherwise. You're not killing the patient, right? Like if you pull 4 teeth and straighten them, and a lot of are trained where you put those models on the table and they line up nice, and you look at the ceph and the interincisal angle's good and mandibular plane angle's good, and if you can do that, it's really easy to sleep at night and just say, look, I'm practicing good orthodontics, I'm developing good occlusions. All that other stuff is just nothing. It's not my job, and I'm not saying that either as a criticism or as a defense. I'm just trying to state the reality of it, that I
Right.
know there are a lot of people in that position. Look, I get it. I've run a practice with almost 20 employees, and you're running around in a million directions, and I own my building, and there's, repair issues. And I mean, it is hard in the middle of that to be like, yeah, I think I'm going to change like the whole way I do this actually. And so I think that's one of the other big obstacles. So you add in the lack of training in our residency programs. And then you look at how difficult it is in the middle of the thick of your practice years to transform the way you do this. I think those are two of the biggest reasons why a lot of orthodontists just really don't want this to be a thing.
I think that is huge. And something, so, a lot of times when you and I hop on, there's like a whole 1 hour conversation before we even hit record. And we were talking about just like psychology and life
Mm-hmm.
and growth, right?
Yep.
And something I'm learning in life that I've learned professionally and just personally over the years is growth usually is extremely uncomfortable. And you usually don't make these huge changes in life because it's something really easy happened to you.
Mm-hmm.
It's usually something uncomfortable, something that pushed you to think differently, behave differently, have to live differently. And I think you hit it like growing pains.
Mm-hmm.
If you're going to change your practice, let's just be transparent. It's going to be a little bumpy at first. It's going to
Mhm.
be uncomfortable, and
Mm.
nobody
Mm.
wants to be uncomfortable.
Mhm.
But when you see that it's so worth it and talk to other colleagues doing it, I highly recommend anybody listening to this. Like, if you're like, oh, the thought, see, yep, Stace, you're saying it. It's going to be uncomfortable. Nope,
Mhm.
I don't want to do it.
Mhm.
But if you could just talk to people and get some testimonials and see the changes. And I think too, it's when you just see the change and you're like, oh my gosh, I'm going to do that again. And then you do it on another kid. And you talk to other
Mm.
colleagues that are doing this. And once you see it, you can't unsee it.
Nope.
The discomfort, the growing pains, stepping out of your paradigm, it's all worth it to do it. But I think that is part of the resistance is change, and it's uncomfortable to change. A lot of times, we'll keep doing something that we know may not be the best for somebody or for our even ourselves
Mhm.
because it's something we're familiar with. And there's comfort in familiarity. And it's like I wake up, I don't even think about it, and I just do it.
Right. Right.
And you do have to change. And like, good grief, God love our teams. They deserve medals for how
Mhm.
many times we've changed. Okay, I'm going to use this form now.
Right.
Instead of this sleep form, I'm using this sleep form. This is a new validated one. Or we're going to change how we schedule. We're going to change what insurance we take. We're going to change. I mean, gosh, Mike, right? Like,
Yeah, no, I still remember when I went to my team the first time and told them we're going to start trying to expand with braces and wires on young kids instead of expanders. And my treatment coordinator, who'd been in the business, even she had a military spouse, so she had moved around and she'd been doing this for a while. It's like the scene from Top Gun where he's like, "You're gonna what?" Like that. Like,
yeah,
wait,
you're going to what?
you're gonna what? Like, what? Like seriously, like they looked at me like Dr. Mike's finally lost it. Like he's finally got off the deep end. And that's such a good point that our teams, and we don't want to make waves, right? Unless the stimulus is severe enough, we can really justify holding course pretty
Yes, all day
easily,
long. I
right?
can
Like,
I can justify it. Yeah.
yeah, and not even not be able to put our heads on the pillow at night like we're deceiving ourselves. I mean, really justify it. Like, hey, look, I'm doing it because you're still doing a lot of good in the community. I mean,
You are.
even
Yeah.
if you're a dentist or orthodontist who doesn't do this or believe in this, at the end of your day, and I think it's important, I don't want to put words in your mouth, but knowing how similarly we think on these things, I'd be willing to bet you'd feel the same way, say otherwise if you don't. But the end of the day, every dentist, orthodontist who's ethical and moral and trying their best is doing a tremendous service for their patients, their community
Yes.
every
Yes.
single day. Whether you are quote unquote airway aware or wanting to treat these kids younger and be involved in that process, it's not that if you're not doing that, you're like a bad practitioner or
Right.
something, and at all. What it means is though, part of your responsibility as a professional in practice, and Trevor Nichols, who was recently on my show, who's just an amazing rock star, younger orthodontist, and he said his one mentor that helped him a lot was when he said early, it's your practice, not your perfect, and
Hmm.
and it's never going to be your perfect. It's always your practice. That being said, our job and our responsibility is to try to improve our practice and our service to our patients and our profession every single day we do this. And it's not enough to just be satisfied doing it the way you've done it the past 10, 20, 30, whatever years. And I mean that for our schools, and I mean that for our colleagues in practice. We've got to use some of that evidence informed decision making. And if we don't want to do it, and you and I have talked about this, you may have no desire to treat, let alone a 4-year-old kid, even a 6, 7-year-old. A lot of orthodontists just aren't comfortable. They're not trained to even treat kids that young. That's totally fine. But to deny that it exists as a problem and that the evidence and data are there to substantiate it, that's where it crosses the line for me. Like, you
Yeah.
don't have to change it. I know it's hard. I wish you would. I think, as you said, once you see a couple of those kiddos, it doesn't take many of
It
those kiddos
doesn't.
to change their lives. It does. Dan Grob was on my show too a recent while back, and really interesting because he practiced for, I think it was 25 years in the traditional orthodontic way. That's why I wanted to talk to him, because I think it's such an interesting story. And then through different life events that happened and professional events, he ended up now that he's much later in his career, and he's practicing in the way that you and I believe, and treating these kids young and going in and helping them grow and looking at airway and cone beam and hearing that transformation in him. And you just see this elation as he gave this example of this mom who stood up in his clinic and was like, you changed my kid's life, you know? And I said, Dan, that's it. That's the why.
That is the why.
Like that's the why. I have never met somebody who does this as hard as the change. And it was hard for him. Like you said, he had some major life events and it was not an easy transition. But I've never met anyone who's changed as you have, I have, Dan in this example, that hasn't been like, I will never go back. And I wish I didn't do it this way now. And I think that speaks volumes because we all are in this because we want to help patients. That's why we went in these professions. And I can tell you, I have had no greater impact on the lives of my patients and their families than through helping detect some of these sleep related issues young and between getting them to the right medical professionals and my growth and development process, changing their lives. I've had nothing that's been more impactful on me.
Isn't that the truth? I feel the same way, Mike. It's I just, I said to Steve Carsonson when I just talked to him recently, and I said, man, what a great profession we have. It's a lot of
Mm.
fun. The opportunity we have to change lives, it's insane. Like I love it. And I think I mean, even just if you look at personalities of people that kind of go into dental medicine, it's really interesting. And we just are, I mean, I just think we're just a great group of humans. And I think
Mm-hmm.
most of us really want to help and we want to help in a different way. And most of us, we chose dentistry for a very specific reason instead of going into just whole medicine. We
Mm-hmm.
wanted the section of the body that we chose for a specific reason.
Mm-hmm.
And the older I am and the longer I've been doing this, it solidifies the difference that we can make as oral physicians, basically. Um, and the impact we can make. And it's
Mm-hmm.
to me, it's probably the most exciting time to be in our profession. And I think the collaboration between, and I don't know how it happened, how the mouth and as Kevin Boyd and Stephen Sheldon say, the craniofacial respiratory complex, which
Yeah, I
is
love
what it
that.
is,
Yep. Yep.
how that got separated from medicine, how we stopped communicating so much. I mean, um, we really need to start, integrating again. Maybe we need to have some medical residents, have a relationship with some dentists and have them visit and see their practices and see how important it is to have that relationship. So when they come out of medical school, they're already comfortable with this collaboration. I think
Yes.
the future, I think it's going to start changing um, faster. I think as much as I want to say, um, those millennials, and those Gen Zers, I think what they are going to do is I think they're going to change the profession for good.
Mm, I agree.
I think they're going to they are more about quality of life. I think our generation, as much as I love our generation, I think we stepped in line. We
Mm-hmm.
did what the generation before us did.
Put your
You
head
go,
down.
you put your head down. This is
Mm-hmm.
what you do. You come out of
Mm-hmm.
dental school. This is what you do. You take out this, you're going to be in debt $1 million. It's just what you're going to do. You're going to work constantly. You're not
Yep.
going to have a life.
Yep.
You're going to own a business. And they're pushing back, going, but I want to do stuff on the weekends and I want to
Yeah.
enjoy my family. And
Yeah.
I think they watched, our parents and us, and they're
Yep.
like, I don't know that I want to be that dogmatic about just putting my head down and moving forward. So I do think the future is bright.
Yep.
I think there's hope. I don't always agree with the millennials and the Gen Zers, but I think they're going to bring some big, much needed change. I think they're more open. I see the pediatric dentist residents
Mm.
very interested in what we're talking about,
Mm-hmm.
more so than like when I speak, even in town. It's usually the same guy. It's usually this older pediatric male, sorry guys, dentist that
I've said often that I think the females are much more alert on
Yeah,
this
I mean,
pediatric airway stuff than the men. So you're not
but the
offending people.
guys are doing it though, man. I
Yeah,
mean, they're
we're
doing it.
catching
Like,
up, but
they
yeah,
really
but
are.
I
They
think a
are.
lot of the trailblazers. I
There's a
think that
lot of women. There's
yeah,
a
the
lot of
women have
women.
just
I do.
recognized the need for this a little sooner,
Yeah,
and
I
yeah,
think
we
the
can be slower.
mother.
I know
Yeah,
sometimes as guys we
but you guys are coming along. I mean, but he was like, I can't imagine ever, treating a 4-year-old in my practice. And he's a pediatric dentist. Like they would
yeah.
never be compliant. And I'm like, oh my gosh, they're actually. And then I had an orthodontist support me at the meeting in town. It was a study club meeting. And she said, actually, I agree with Stacy that believe it or not, I mean, the 4 and 5-year-old with their Invisalign trays or what have you, they are a lot easier to work on and to work with than the
Mhm.
9 and 10-year-old. So
Or the
sometimes,
13 and 14-year-old who
oh,
a
or the
15-year-old who has
13,
practice this many hours a day and
oh,
has
they're so
studying and
busy
oh they're so
and
busy
they've
and it's
got the
like
tude and they're not
and they eat
listening.
all the time, like literally having two
Yes,
teenage kids, like
they're
they,
constantly eating.
they're like, and so I would face it with my patients as Invisalign teen. I never loved it, not because it doesn't work, but because of the patients. The burnout rate's like, I don't know, like a minute until the novelty of these things wear off on the teenagers. And they're so busy. They're like, well, I have practice from this time to this time, and then I have this from this, and then I'm drinking this during that, and can I eat? And then I eat, and then I'm like, I mean, it was before my kids were teens. And then when my kids got to that age, and I mean, my kids, I put both my kids in braces, not in Invisalign, because their lives were not
There
conducive
it wasn't,
to
and
it.
I
It's
will
just,
say that it's interesting because the teenager with Invisalign is much different than the 4 and 5-year-old, and this is something Kevin Boyd said, with behavior management, and he has such a good point on the recent podcast with him. He was like, these kids, little kids want to please their parents.
yes, yes,
Work with that behavior,
yes.
work with that psychology. They
That's
really
such a good point.
do.
Yeah, he had
They're
some great points on the psychological side of this in your episode. It was a great interview, and he really opened up. I didn't know about his background in psych, and it was fairly fascinating to hear so much of that.
Yeah, and he's big into just diet and I mean, I like you said earlier, the microbiome, all of this, it's coming out. By the way, the ADA has a brochure. It has a brochure on pediatric airway health and for people not knowing how to start these conversations and
Oh, okay.
the ADA sells these brochures. I think there's a code sleep 10. If you use sleep 10, you get a
Oh, okay.
10%.
I'll try to put it in the notes of.
Yeah. So it's just how to start a conversation with parents and the ADA, um, they have, when something has the ADA seal of approval, it does have clout.
Mhm.
And so for them to come out with a brochure on how to have conversations and the importance of sleep and airway health and orthodontic intervention in children, that's huge. So I highly recommend people get some of those brochures in their offices. But now Kevin Boyd was also instrumental in a new brochure on diet. So the importance of
Yes.
diet and they now have a brochure on that. But even just speaking with Dr. Anne Marie Morse, she's amazing. I had a podcast with her. I got to speak with her at Transform Dental Sleep on stage. And what is coming out about gut health
Mm.
and even oxygen desaturations with poor gut health? I mean, this is very complex. The point being, it's not so complex you should just give up. It's so complex, meaning all of us as healthcare providers have a role.
Yep. And
And we
Hippocrates knew
all
it a couple thousand years ago, right? All disease starts
yes,
in the gut. I mean, it
it
was
starts in the gut. It's
just
like
like
your
Engel, the
other
founder of our
brain.
profession, knew there was an airway implication when he said mouth breathing of all the causes of malocclusion, mouth breathing is the most potent, something to that effect.
Yes.
It's like all these, it's like they're clairvoyant, these founders
Yes.
of our certain professions, countries, all these people. It's like, how did they see this coming back? And we're still arguing that they're
And we're
wrong, but
still they probably would be just like, "You're still arguing
you're
about this?"
still, exactly
They're
really
they're
like you're,
probably like, "What?"
yeah,
Yeah,
yep.
it's
It's we're a
crazy.
little
Here
slow
we
on
and
the
with all
uptake.
the advances we have, it's like we're actually just uncovering just how amazing the healthcare providers, the philosophers, the
Mhm.
everybody's shoulders that we're standing on for centuries. We're
Yeah.
standing on their shoulders. And now we can actually, it's just more than their opinion.
Yeah.
We
Yeah.
can
Or they
prove
didn't, what did they know? They had,
what did they
written
know?
on
They didn't have a
tablets, like it's
CBCT and a,
right. Right.
they didn't have an endoscope. Now we know, yeah, they were onto something, weren't they? Too bad it didn't catch on.
Yeah, that
But
human intuition that they had, they intuitively sent, because they didn't have all these the technology as a crutch, and all of
good
these
point.
other ways to analyze that we rely so heavily on. They had to rely on their intuition, and human intuition is a very powerful thing.
Yes,
We
it's
often
one of
don't.
our senses.
It's one of how we got to be such the dominant species, right? I mean,
Yes, it is
we
one of
are.
our, it's what makes us human.
Yeah. I mean, that
And
intuition, we're going
mhm,
through the whole AI conversation now. And can it have, what is the one thing that people question? Well, once it gets emotion and intuition, that's when it's going to cross over and become sort of something that, rivals that's the human mind. And that's what these people had, because they couldn't rely on the technology. So they had to use that to tap into that deeper sense. I think we've all been there when whether it's in our clinics, whether it's with our families, whether it's in a sort of incident where like there's about an accident about to happen in front of you, or whatever's happening in your life that's like sudden, and you just have to rely on your instincts.
mhm.
You sometimes after the fact go, how did I do that? How did I make that decision, split second, somewhat seem like unconscious decision? Your intuition, your instincts, there's a power of your part of your body and your brain that you tapped into. And I think those founding, in this case typically fathers of these professions, they relied on those in they had an ability to tap into them greater than the average person,
And
greater than
like
the
you
average
said,
human.
because they didn't have all the other technology to sometimes be a crutch, that
Yes.
sometimes, like what we're doing right now, so much, we keep saying evidence based, which it's more than literature,
Yeah.
and it's more than all of the high tech. It's great that we have these things. It's amazing that we have these things, but let us not throw out our logic
Yes.
and
Right.
intuition
Right. An instinct.
and
And like
instincts
when you see
too.
a kid that's suffering at that age, I mean, instinctively, as you said, and it's such a great point, to talk about what you would do with a child who wasn't breathing well if they weren't sleeping, right? And so if they were suffocating when they weren't sleeping. So I think it was when you're saying with David McIntosh and that example of the strangling your child. Now, one thing I want to mention that I thought was, I'm really glad you brought up, because I've talked about it to some people on the show, and I want to hear your thoughts. So the one of the other obstacles, your point was about getting the physicians and the dentists kind of coordinating more and cross training them, which is I love, and I really feel needs to happen. I have said I can't believe that and as I go to teach at NSU, and they're there, and as I'm walking through, I mean, I don't know who's a med, as I'm walking in towards the building and into the building, I don't know who's a med student and a dental student. They're all dressed in scrubs. Like, we're right there with one another. Like, really? I mean, for all these years, the dental and the medical students in Stony Brook, we were actually in the same classes with them for 2 years,
Yes, same.
the
Yeah.
first 2 years.
Yeah.
So we have this experience where we're together. We're not coordinating. And I think, again, I'm calling on the department heads of these programs to start to develop initiatives to cross train their residents. If the system in orthodontics right now is broken such that with the Salzman index, they're not able to treat these kids younger, which is the
Right.
way it is, that, we've referenced that they can't get these kids young because of the way a lot of them are on state funding, and they can't afford private pay in some of these situations. And they're at the dental school or the clinic as for that reason, because it's lower cost of care, or Medicaid will cover it. They get a qualification standard, a medical necessity index, called the Salzman index, developed in 1968. Not really relevant for today in terms of what we need to look at. So they won't cover a child who presents at, say, 6, 7 years old, or let alone 4, with narrow arches, insufficient tongue space, all these other symptoms that we've spent a lot of time talking about on this and other shows. They won't cover them for it. So what's your only option? Your only option is to send them to get teeth pulled, because you have to make room for those next teeth to come in, or you have even bigger problems.
Hmm.
I know that is a system that's going to be hard to change anytime soon. You're talking about politics, money, funding, so that's going to be a kind of a longer term goal. But short term, if the orthodontists say, well, we can't get kids in that early, we don't treat them. We'll get your orthodontic residents with the pediatric residents and start getting them
Yes.
comfortable in some of the tell, show, do techniques and working on these younger mouths or doing some prophies on younger kids to just start to feel what it's like to understand how to work on them. Because I said to the orthodontist, our general dental and pediatric colleagues, they've worked on young kids. They're not scared of it. Orthodontists, by and large, are like, I don't know what to do with a 7-year-old, let
It's
alone
the
a 4-year-old.
behavior management side of things. If we could
Completely.
communicate and have the ortho residents with the pediatric residents who are
Right.
learning Frankel scores and they're
Right.
understanding how to handle these kids at these young ages. And it's like, hey, we see the craniofacial issues. I mean, gosh, Mike, 100%. Like, why aren't we on a academic level getting everyone integrated more,
Right.
um, these programs integrated more so that we can continue that continuity of care and be more comfortable collaborating and referring appropriately. It's just, we're in this department. We're
Yes.
in this
So
department.
siloed. So
Very
siloed.
siloed.
It's siloed across the disciplines of medicine and dentistry, and then within the specialties,
Yes.
in generalists, it's siloed again. It's like double siloed here.
But our bodies aren't siloed.
And
Our
that was the point you made that made me think of it, is talking about how the mouth got separated. And I really think it's because, as educationally, I mean, if you think about it, our eyes are kind of separated, right? I mean, our you have a special or cardiology, or you go to the ophthalmologist or the optometrist. And we have these little subspecialties. And
yeah.
last time I checked, my ophthalmologist isn't exactly coordinating or talking with my primary care or with my dentist or with my allergist, right? Like, they maybe we'll send a letter back and forth to put in each other's charts, but it's not like, and then, you get so little time with the primary care, your annual, where maybe you get 5 minutes where you can try to catch them up on. So the system is broken for that way. So while we're not going to be able to change the system right away, what we could change is the educational part to
Right.
get people comfortable with this stuff, so that in medicine and in dentistry, we're not so intimidated by what the other person is doing and so unaware of it. And I think that would go a long way to help. I know from the orthodontic side, actually, that when I ask orthodontic residents or young orthodontists, are you comfortable treating even a 6 or 7-year-old that walks in your office if you're alone and have no one else to ask, or no, majority aren't. And not even just from a technique execution perspective, but from a behavior, as you said, the behavior management perspective. They're not trained in it. I've said often, if it weren't for the training I got at Stony Brook from Dr. Fred Ferguson in treating children with disabilities and just in a pediatric clinic, he was an amazing pediatric dentist. I don't know if I would be sitting here talking to you right now about this, because I probably wouldn't have been as comfortable treating those younger kiddos. Now, once you learn how to do it, they're easier. They're more, you could tip them upside down if you needed to.
Yeah, they're so, yes.
Compare that to doing a crown prep on a second molar on a 75-year-old. And it's like, but I'll
Yes.
take the young kiddo any day.
Any day.
But they're just so easy in that way. But if you don't have the appropriate behavior and patient management, and I think this is one part we're not, and we as in the group of, are really wanting this concept of airway and airway health and breathing health to penetrate a broader audience. I don't think we're talking enough about the lack of training in treating those young kiddos that is happening, especially in the orthodontic profession. And you're asking orthodontists to leave in all this debt, with all these years of school, spending all this time learning how to straighten teeth, and then going and telling them, now you're going to go start treating these young kids that you've never been trained to treat. And
yeah,
I don't think people are thinking about that enough.
Right. And it's, again, I think underneath a lot of this is fear of discomfort, fear of, the financial ramifications, the team being, just upheavaled and learning.
Right. If you walk into someone
new.
else's practice as an orthodontist, are you going to be the new associate and start saying, oh yeah, by the way, let's start taking 4-year-olds?
Yeah. I'd love to start seeing 3 and 4-year-olds, please. They'll be like, and the next associate, when are we interviewing?
Yes. Today is your last day. Thank you.
Yeah. Today was your last day. Thanks for playing.
Yeah.
It's so true, Mike. It's so true. But here's
and then by the time, sorry to catch up, and then by the time they're in that system playing the way they have to play, and I'm not faulting them. You can't go in as the new person and like rock the boat and toss the apple cart over it all at once. So let's say you now are a couple years in, maybe you're starting to get some ownership in the practice. Now, all of a sudden, that you've been doing it this way for a couple of years, now it's significantly harder to start to do it that
Yes.
way.
Yeah. But I think identifying all the obstacles at least is getting it out there, and there are movers and shakers,
Mm.
and we know some of them,
Mm-hmm.
that are out there changing academics as we speak. Um, and I think they are growing, and uh, the future orthodontists as well, and they're going to be movers and shakers. And like you and I have said before, hopefully in 5 years, like the stuff we're even saying right now is like we're onto a whole new topic
Yeah.
because we're
Yeah.
seeing the change. Um, and we can reference our podcast is remember back when they didn't
Right.
even look at kids. I mean, that's the that's the dream, is hopefully what we're saying someday just becomes a thing of the past, what we're talking about. But
Mm-hmm.
um I think it's really, and this is, I think you were going to start, you and Kevin Boyd have been talking back and forth. He's definitely a mover and a shaker. Steve
Yep.
Carsonson is a mover and a shaker. And they've
Yep.
made some big changes with the American Dental Association.
Yes, I'm trying to coordinate with, in addition to with Kevin, with Steve and Jerry Simmons, having them come on and
Oh,
talk.
good. Jerry Simmons.
Yes.
Oh,
Yep. Getting them
yeah.
together. We did kind of a prep call and the cast program that they're doing with the ADA and
Yes.
the scoring screening. Karen Parker Davidson, I'm going to have
Yes.
on with
Yes. Oh, gosh. She's
rhinometry. And
great.
I had a great talk with Bill Harrell, who was just awesome. And he then had me give a guest lecture to the University of Alabama Birmingham residents on. So that's exactly what you're saying, is that's how this needs to, because it can't be a top down approach yet.
Not yet.
Hopefully it will. We're not going to give
Yeah.
up on that, but it does need to be more of a grassroots approach at this point.
It is a grassroots. That's so funny too. The pediatric neuro that I was talking with, Anne Marie Morris, she was talking about how it seems more grassroots. Also, Allison Cole, she's a sleep physician. She has a podcast, Sleep is My Waking Passion.
Mm,
And she had me on and she said, what is it about this with especially the pediatric movement? It's definitely more grassroots. I said,
mm,
it sure is.
mm-hmm,
And it's, and I think parents, I'm telling you, who drives all of this?
mm-hmm,
Parents
mm-hmm.
demanding it,
Yep.
parents educating themselves, parents
Yes.
asking for it. So, those of you that are parents listening, you have to be your child's advocate,
Demand it.
demand it. And if you
Yep.
don't get it, go to somebody else.
Yep. Or
And you
reach out to
just,
us and see if we
yeah,
can
and we can hook you up with someone
try
in
to
your
put you in
town
touch with someone.
because you deserve it. Your child deserves it.
Yep.
And you deserve a whole body approach and someone that looks at your child as a whole person,
Yep.
not just teeth, just
Yes.
there's an airway above it, behind it, below it. And, but
I love,
anyway,
yeah, the parent, that's so well said, because as we kind of, to tie that back in, what we were talking about generationally, I do feel as the millennials and Gen Z start having kids with that different mentality they have with the internet and podcasts and I mean, there's just so much
oh,
exposure to
so
things,
different now.
so different. They're seeing this, and what I hear from parents all the time that reach out to me, that follow my content, they're like, what you described in your podcast or your course, some of my earlier podcasts, like, actually did some educational content, not just conversational. And they're like, that's my kid. That's my kid. And I went to the orthodontist, or they were going to pull teeth or whatever it is. And they're becoming an educated consumer. And they, I think, are, that you're 110% correct. They are going to play a huge role in driving the change.
Agreed, friend. I
Yeah.
agree. We usually always agree, Mike.
I know. I know. We share an interesting brain wavelength, I think, that we operate
It's
on, a
funny.
frequency. Yeah, no,
You're like a
I always,
brother from another mother. I'm like,
I completely agree. Yeah, I always so enjoy talking to you, and the
same
time
here.
always
Same
flies
here.
by as we chat about whatever we're talking about. But no, it's you keep doing what you're doing.
Same to you, friend.
You're doing such great things, and as I said, you're great with the podcast and the content you're putting out there. And I know it's not easy, time
No.
wise, energy wise. I don't know
Yes.
how. you are finding the time to do a lot of what you're doing in terms of still getting the content out. But even if you can't always do it in the volume you want at a certain time, just the quality of what you're doing when you do it is so valuable. So thank you
Thank
for
you,
that.
Mike. And thank you for yours as well. And I think too, we share some of the same guests. And what's interesting
mm,
is we might even have the same guest on, but our conversations go into different places
mhm.
too. And we grab different information. And I think us doing these touching base with each other, podcasts are super great too, because I'm learning from you and I am thinking even like, oh my gosh, I do need to contact Bill Harrell. I know Bill Harrell. I need to get him. And so
Yeah,
it's just like, but
feels great.
it's just having these conversations, empowering the parent, the
Yep.
healthcare provider, and having more conversations, and wish more people would have these kinds of conversations. So I
I
appreciate you
completely
being on. Hey,
agree.
can I ask you my 3 questions really quick that I always like
Sure.
to ask? So I
Yeah,
got some
let's do it.
different ones for you,
Okay.
Mike.
Uh-oh.
Okay. First of all, what
Mhm.
is your biggest pet peeve?
Sadly, I
Drives
probably
you
have more of
bonkers.
them, more of them. I should
It's hard to
sometimes.
pick which, right?
Yes, but I think overall, the one that encompasses a lot of others is disrespect.
Ooh, yeah.
Disrespect, because there's a lot that fall under that and things that people do, little actions. But when it comes from a place of disrespect, you can disagree. You cannot have. You can believe different things, feel different things, but when you don't respect another person's point of view or stance or space or whatever it is, to me, that'd probably be the top
Yeah.
violator.
Oh, that resonates with me as well.
Mhm.
It's very visceral. Ugh,
Yes.
when I
Yep.
witness it, I'm like, ooh,
Yep.
injustice.
Even
I
if you
don't like it.
disrespect a place, like
Mhm.
like throwing garbage out the window under, like, just like that. Like, just be respectful of others, of your environment. Like, yeah, I don't,
Yes,
we're all gonna think, believe, have different views on things, but if we all just are respectful of our environment and the people around us, I think that can go a long way.
agreed. Agreed. When are you the most productive?
Night. I'm a night owl.
Are
Yeah.
you?
Oh yeah. Yeah. I sit up even to this day. I mean, it's I girls are all, my daughters and wife are asleep, and I'm up just kind of I'm much better on sleep. It used to, the tough part of that is when I was running my practice full time, doing everything I was doing, I would compromise because I like working at night. Always have, even back to the medical school part of dental school, when you're studying for the huge, cells exams and anatomy exams, I would be up late. I love that time. I just dig in. My brain's wired that way. But it was tough when I had to get up early. We had
Mhm.
little ones, and then with the practice, I had to be up early, and so that was hard. Now that I can adjust my schedule more, and I can be really hyper productive at night, and still get better sleep, and get a longer night's sleep. That's been sweet. But even though now I can make my own schedule, I would be during practice, I'd go to the gym at like 9:30, 10 at night.
Oh
I mean, they're not
gosh.
supposed to, but
Wow.
I tried doing it in the morning and I just hated it. I hated
Yeah.
it. And for me, it's cathartic. It's let out your day. I don't do that now because it's just not as healthy of a way to do it if you can choose. But I still like an after worky. My workout routine is, I do, some light exercise stuff during the earlier part of the day, but my workout comes at the end of the day.
At
Yep.
night. Oh
It's
gosh.
evening now, at 5 o'clock,
Yes.
six
Well,
o'clock
we're
time. But
getting older, Mike. I
I
mean,
know I got to rein it in a little bit.
you
Can't be
gotta
staying up. Yeah.
can't
But
be
no, I'm,
staying
I'm a
up
night
till
owl. Yeah.
9:30.
How about you? What,
I'm
are
a
you the opposite?
morning
Are
person.
you? Okay.
Yeah,
We
so
found a place that
I
we're not
this is
connecting
where we're
there.
like,
Yep.
okay, the yin to my yang, but
Yep.
I'm more of a morning person. I'd rather get up, knock some things out, have a
Mhm.
cup of coffee, get going. I get more
Mhm.
done probably by 9 a.m. than I'm a morning person. I've always been like, boom, I open my eyes, I'm up. My
Hmm.
oldest son is the same way as me. It's like
Isn't
you
that
just
funny?
walk in and say, good morning. I'm like, I'm ready, let's go. And
Wow.
I love to be in bed. I love to be in bed by 8:30, 9 o'clock. It is like,
Wow.
I can't wait to be in bed. But it's because I get up so early.
That's more Renee. That's more her. Yeah, yeah. Which kind of works well because we laugh. We get to take kind of shifts with the kids. I do
Oh, that's
even
good.
did when they were little, like infants. I do the night shift. She do the morning shift, and it actually worked out quite well. That we are that way. We have always been wired that way.
Ah, that's so
Yeah.
funny. Everybody's so different. Thank God
Mm-hmm.
it takes everyone to make the world go round.
Yep.
And then what do you wish you knew before you started your career?
My orthodontic career in general, or this
Yeah.
next phase of teaching
Well, how about
exclusively?
this next phase of teaching? What about that? What do you wish you knew before you started this next phase?
That's a great question. I wish I knew more about how to market and get my message out there. I'm just not a good marketer, advertiser. You know, my goal, my approach has always been build something that's substantial and of great quality, and people will find it. And it's just, I'm realizing that's not really the world today. You've got to have more of a. I'm not comfortable in the social media thing.
Yeah.
If you look at my personal social media page, I update my profile pictures every few months, and that's kind of the end of it. I'm not a big poster. I'm not like I'm private, and I just don't, I'm not big on like
I'm
throwing
not
everything out there.
either.
Yeah, it's just not comfortable for me. And I know if I did that, I could probably get my message out there to more people more quickly. And I could have I struggle with that because I want to have an impact and help change these kids' lives and get the message out of all this content that I'm building and so passionate about. But I also want to stay true to myself and what who I am and what I am. And I'm just not the type who's going to film nothing wrong with this. I want to say, I don't mind,
Right.
people do, but I'm just not the type who's going to film myself at the gym. And I've struggled with that. And I know people do it, and it would certainly let me reach more people and get more followers. But I'm not saying I never would even try things like, I struggle with that. So I wish I knew how much of a struggle that was going to be and knew how to market myself better, but stay in a way that stayed true to who I am and what my values are and what I'm comfortable with. But also let me be a little more effective on the marketing side. I'm just not in my practice. I was fortunate. I really, I did the sponsored teams and all that school
Right.
events. And I loved that stuff to give to my community, but I didn't put ads up. I didn't run advertisements. I
I
didn't have
also
ads.
think it was a different time for both of us
That's
too.
it.
And
Yes.
I
You can't do
struggle
that
with the
now.
same
Yeah.
thing.
Do you?
Oh gosh, yeah, I'm so private. I do think I'm private. I
Mm.
don't like to say, getting up, making my breakfast and
Yeah. Yeah.
post it
Yeah.
and here's what I
Yeah.
eat. And I
Yeah.
just don't do that. And
We sound so old, but I feel the
I
same.
do. We sound so old.
I
And
feel the same way.
so I guess this is a cry for help. Anybody listening that wants to help us,
You know how to take some Gen
two
Xers,
Gen Xers and
Who are not comfortable with this thing and rehabilitate us here.
yes,
Yeah, I mean,
they're
yeah,
like,
it's so
there's
funny.
got to be somebody out there. They're like, I can represent your authentic self, Mike. So
Yeah,
maybe somebody will reach out to you from all
I
of this.
love
But
it. I love it.
anyway, friend, always good
Same
to
here.
hang out and have conversations. And until next time,
Yeah. Until next time. So great to talk with you and be with you
same.
as always. Continued much success. Keep kicking butt and doing what you're doing, and
You
we'll catch
too.
up again soon.
Sounds good. Bye, everybody.
All right. Bye, everyone. Take care. Stacy.